Good afternoon, everyone. My name's Shelley Morris-King. I'm the consultant psychologist, and I support the psychology service that works across the rehab network, from the inpatient hub and spoke all the way through into the community specialist team for Liverpool and Sefton. I'm going to do a bit of a whistle-stop tour today about some of the psychological issues that we see post-traumatic brain injury, but also I'm going to talk a little bit about the work that we do as a psychology service across the network. And I'm going to whiz through it quite quickly because I've got a short video that I was hoping we'd be able to watch of a service user talking a little bit about their experience of psychological issues post-TBI and also their experience of rehab. I'm going to just talk really quickly when we talk about rehab. It's kind of inevitable that we also end up talking about trauma. And just to say that the increases in terms of the expertise and knowledge of trauma patients and their treatment has had a knock-on effect for the sort of work that we're doing from a rehab perspective. So trauma is a major cause of debilitating long-term injuries, and for each trauma fatality there are 2 survivors with serious or permanent disability. And from a psychological perspective, we're really interested in those survivors and working with them. Quite a lot of the time I get asked this question: what is the role of psychology within rehabilitation? And I guess it's about understanding that trauma warrants more than just a medical approach, because trauma is really essentially a human experience. The consequences are psychological, emotional, they're interpersonal, they're vocational, they're cognitive, and they're behavioural. And psychologists are really well placed to deal with a whole range of these issues. We're really interested as well in neurorehabilitation and incorporating and understanding an individual's cognitive strengths and weaknesses, the identification of goals and skills development. But particularly for this service, which works within this new pathway, we have what we refer to as a holistic approach, and we're really interested in not just the individual, but their communication and behaviour, their family and friends, their work and activities, the identity and self, environmental management, social issues, well-being. And the foundation of our psychology service is very firmly rooted within a human rights-based approach, which applies the FREEDA principles of freedom, respect, equality, dignity and autonomy. We're really interested as well in the phenomenological perspective, so the lived experience of service users, the normalisation of difficulties relating to psychological adjustment to long-term disability, and formulation-driven care as well, which allows individualised treatment based on who the person was before the accident. Our additional support that we provide as a team includes teaching and training to the wider MDT. As Kevin said, we're also part of the capacity assessment and safeguarding issues. We provide psychological consultation and advice for complex cases, reflective practice for the team, leadership and management, support for the staff team, and we were really involved in the development of the vision and values that we developed for the network, because we wanted those to be linked very closely to the FREEDA principles to ensure that we had a person-centred approach. So Kevin's covered a lot of the different long-term impact of ABI, which are physical, sensory, communication, and from a psychological perspective, we're particularly interested in the cognitive, the behavioural, and the emotional. Obviously, we're aware that there are attention and concentration, memory, perceptual difficulties, and executive functioning difficulties. We know about difficulties with aggression and frustration and irritability, non-compliance or poor engagement from things like post-traumatic amnesia. We advise on things like fatigue management and management of pain, sleep disorders, which can be related to both pituitary damage and hormone dysregulation, and as Kevin mentioned, also PTSD, which is quite a controversial condition following TBI, but more recent research has found that PTSD can be diagnosed. And this is just to kind of show some of the impact that TBI can have on people from a psychological perspective. So changes to their sense of self, their identity, changes in their role, but also changes within the wider systems in terms of finance, work, responsibilities, family, social networks, society, and stigma. And we're quite influenced as a team by the work of Fergus Gracie, Jonathan Evans and Donna Malley at Glasgow University, who talk about a Y-shaped model in terms of neurorehabilitation, which is again looking at having a really holistic assessment of a person, which looks at them as more beyond just their diagnosis or their injury. This is just to talk really briefly about the patient journey through the network and where we provide psychology. And we're unusual in terms of a psychology service that we're firmly embedded with the MDT. So we're not a separate referral-only service. We're part of that MDT. We go along to every multidisciplinary team discussion. We're present at goal-setting meetings. We discuss complex cases and capacity assessments. And this is to just outline some of the different types of work that we might do with people at different stages of their rehabilitation journey. The aim of psychology really is to support individuals to engage in the rehab process. One of the things that we do on Lipton Ward is something called one-page profiles, which is something that we've borrowed from the learning disability background. And this is just a one-page profile, one single sheet of paper, and under 3 simple headings, we ask what people appreciate about me, what's important to me, and how best to support me. And it's for individuals who can't perhaps engage in psychology, but we're starting to work with their family and friends to get a sense of who they are as a person and what's important to them. And it's probably one of the first times that these type of person-centred practices have been brought into a really acute medical setting to ensure that people are seen as more than a diagnosis or a collection of symptoms or an impairment or disability. It's part of our role as well to raise psychological awareness across the whole MDT. And we're really asking all of our colleagues that we work with to think psychologically with regards to rehabilitation, to employ motivational techniques and strategies to support rehab. We've got a big role in supporting patients, carers and families with regards to understanding the injury, disability or impairment. Also helping them to manage their expectations, to think about their psychological response, acceptance of the situation and plan for the future. And we signpost and refer on to other services, and then that is one of the unique selling points of the network, that it's often the same psychology service that works with somebody all the way from hyperacute all the way through into the community service. And often if we had to refer these people onto a community mental health team, the support that they get wouldn't be as good as it could be because of the lack of understanding around things like acquired brain injury or cognitive impairment. Some of the one-to-one and group interventions that we provide is around support for the individual to understand what's happened and to normalise that emotional journey. And actually, we don't pathologise what is a normal psychological response to an extraordinary set of circumstances. We work with therapists to manage emotional distress during therapy. We provide individual therapy to support emotional difficulties. We work jointly, particularly with our colleagues in occupational therapy, around neuropsych assessment and intervention, providing compensatory strategies. And we provide assessment and management of challenging behaviour. And one of our assistants has just done a really excellent piece of work on Lipton Ward, doing some really detailed guidance for nursing staff and the wider MDT based on the use of the overt behaviour scale and her observations around challenging behaviour. And we also do some group work around psychological intervention, which enables peer support as well. So we're encouraging other people to talk about their experiences and learn from one another. We've got a specific role in supporting families and carers who are actually often more psychologically traumatised by the event or the injury than the patient themselves. So the journey from A&E through to intensive care and then onto the rehab unit is often a real emotional roller coaster for families and carers. And part of our role is supporting those people. We're very proud of the psychoeducation group that's being developed and delivered jointly by occupational therapy and psychology, which is for carers and families. And a big component of that is highlighting the importance of self-care strategies and support for families and carers. And again, we offer one-to-one support. We encourage families to link in with other local services, access counselling services, and we highlight the role of voluntary agencies such as Headway, Neuro Support, the Stroke Association, and so on. So just wanted to talk really briefly about some of the ways that you might describe rehabilitation, and there's a couple of definitions here. But this is kind of my favourite definition, that rehabilitation comes from the French word habiter, to live or inhabit, or to live inside oneself again, to get back to who we are.